our next speaker is Krista Huybrechts, who's going to be talking about a critical review of the literature. Krista is a pharmacoepidemiologist who's devoted her career to studies of drugs and pregnancy, and she's recently completed a major analysis of risk of autistic spectrum disorder in relation to drugs and exposures in pregnancy. Krista?
Well, good afternoon, everyone, and thank you for the kind introduction. In the interest of time, we'll delve right into the evidence. And one of the earliest studies that sort of gave rise to this concern was an ecological study where the investigators looked at the correlation between perinatal exposure to acetaminophen and the prevalence of autism spectrum disorder in the population. They looked at data from 8 different countries, and as you see here in the graph, sort of detected this positive correlation, which gave rise to the hypothesis that acetaminophen might be responsible for an increased risk in autism spectrum disorder, and led them to really encourage the field to look into this particular association. Now, I think most of you here know the limitations of ecological studies, and I just wanted to try and illustrate how misleading ecological study evidence can be. So what I did is basically I replicated exactly what the investigators did, but used data from 6 different European cohorts, but again, plotting the perinatal use of acetaminophen and the prevalence of autism spectrum disorder. And what you see is actually an inverse association, which is almost as strong as the association in the original publication, which should then give rise to the hypothesis that maybe acetaminophen reduces the risk of autism. It is also informative to look at trends over time within a given country. And here I'm looking at the US, and as we all know, as it's just been described, there has been an increase, at least in the recording of autism spectrum disorder over time, as you see here based on data from the CDC. Now, if we look at the use of acetaminophen during pregnancy over the same time period, so these time axes are aligned here, then you see that there's actually no evidence that the use of acetaminophen is increasing. If anything, there's a little bit of a decrease over time. It hovers at around 60%. So again, no support for that initial hypothesis that sort of gives rise to so much concern and led to so many studies being conducted, actually all referring back to this initial study. So, but what do we know about acetaminophen use in pregnancy in the US? I've just shown you that the use is relatively stable over time. We also know that 97% is a use over the counter. And most of the use during pregnancy is actually really short term. More than around 65% of women report that they use it for less than 10 days. The discussion the last several months and over time has really focused on fever, but actually fever is not the most common indication. About 8% of women report that they use it for fever. The vast majority of women actually use it during pregnancy for headache, migraine, and other pain indications. And finally, what we also know is that women that report using acetaminophen during pregnancy have a lot of other comorbid conditions. They have a higher risk of mental health condition, higher prevalence of hypertension, autoimmune conditions, asthma, and so forth. All things that are important when we're going to think about potential confounding in the studies that have been conducted. And before I'm going to take you to the literature, I just wanted to share this simplified deck, which I used myself to sort of go through this literature and try and identify the points that I wanted to pay specific attention to. So we know that for both acetaminophen and autism spectrum disorder is actually measured with error, right? The misclassification can be non-differential, it can be differential, and it can be dependent. As in any observational study, we really have to be concerned about potential confounding variables, indication itself, but we also talked about these other comorbid conditions that are more prevalent among women that use acetaminophen. But then there's also the familial factors, socioeconomic status, and so forth. There is also emerging evidence that autism and certain pain syndromes actually share common genetic and neurobiological pathways, in particular with respect to sensory processing and neural excitability, as was just discussed. So the genetic component is something that we definitely want to keep in mind. And then as I was reviewing the literature, what I noticed is actually a lot of studies adjusted for these post-exposure variables like preterm birth, low birth weight, small for gestational age. So these are just a couple of examples. But these factors actually share common causes with autism itself. And as you can see based on the DAC, if you're going to adjust for those variables, you actually risk opening up a backdoor path and introducing confounding. And most of the studies I reviewed actually had very suboptimal control for these confounding factors, and a lot of them actually adjusted for these post-exposure variables. So I'm not going to repeat it with every study that I'll discuss. Just keep in mind that most studies actually are not doing a good job in terms of confounding control. And then finally, what I wanted to mention is, as I went through the studies, I sort of classified them based on their risk of bias very roughly into three main categories. So what I'll indicate with red is sort of high risk of bias, orange is sort of that medium risk of bias, and green is low risk of bias. So look out for those indications on the next couple of slides. So but let's start looking at the different studies. So the first study from Avella Garcia was a cohort study conducted in Spain, included 1,589 patients. Exposure was based on interviews conducted during pregnancy. And in terms of the outcome, it was based on scoring on the Childhood Autism Spectrum Test, or the CAST, which was assessed at 5 years of age. That test has a score range between 0 and 32, and 1 point actually corresponds to 1 symptom. So what did the authors report? Overall, there was no association between acetaminophen and the score on the test, but they do report an increase of risk in the male offspring. They highlight that a lot in their write-up of the study. What they don't put a lot of emphasis on, but what is actually also reported in the result, is that for females, they actually see a protective effect, so a lower risk of autism in females after exposure in utero to acetaminophen. I classified this study in sort of the orange label, so intermediate level, mostly because of suboptimal confounding control. But I also want to draw attention to this sort of odd finding, like why would there be an increased risk in the males, but a protective effect in the females? And the other issue I wanted to point out is that it sort of raises questions about the clinical implications, because so the difference is less than 1 point. And remember, I said 1 point is 1 symptom. The cutoff for autism on this particular scale is 15, but authors don't tell us like how close these kids are to reaching that cutoff for autism. So moving on to the next study by Lou and colleagues. So this was a study using a national birth cohort in Denmark, included 4,322 patients. Exposure was also assessed based on interviews conducted during pregnancy. And here the outcome is based on a hospital diagnosis for ASD with an average follow-up of 13 years. Overall, the relative risk was 1.19, but the authors really drew attention to the fact that the effect was seen among children that had ASD as well as hyperkinetic symptoms. So you see a relative risk that is about 1.5. In children without hyperkinetic symptoms, there was basically no association. I must say that this differential effect, depending on the presence of hyperkinetic symptoms, is not replicated in any of the other studies that I looked at. And these investigators were also not able to identify what might have been like the vulnerable time window during pregnancy. So they looked at individual trimester, they looked at combinations of trimesters, and nothing really stood out. The results were a little bit all over the place. What they did find is that the risk was stronger with longer duration of treatment, so greater than 20 weeks, or exposure in all 3 trimesters. Time does fly when you're standing up here. Moving on to the G study. So this is a prospective cohort from Boston Medical Center, including close to 1,000 patients. They ascertained exposure based on the presence of acetaminophen metabolites in the cord plasma at birth. And what I want to draw attention to here is that actually 100% of the kids were exposed. So this raises some question in terms of which sample was selected here, because we know that acetaminophen has a very short half-life. So this really means that all of these women were exposed right before delivery, which must be the fact that they received it for infection, chorioamnionitis, and so forth, but a very select sample. In addition, so the outcome is based on diagnosis present in the medical record at Boston Medical Center. So raises the question, like, who are these kids that remain under surveillance at Boston Medical Center? So huge potential for selection bias. I think we can see it here that the prevalence of autism in this cohort is 11%. The prevalence of any neurodevelopmental disorder, 67%. So although in terms of like the associations themselves, so everybody was exposed, so they're only looking at tertiles of exposure. They don't give us the absolute levels and actually compare the second to the first tertile and the third to the first tertile, and we see very strong effects. I put, however, a red indicator there because I think this is a very select sample and I'm really concerned about selection bias here. Moving on to the next study, Alemani. This is in essence meta-analyses of 6 European cohorts, and this is actually the individual cohorts that I used to sort of show how misleading the ecological studies can be. In total, they had about 74,000 patients. Exposure was based on interviews during pregnancy. They were all conducted at different time points during pregnancy. And the outcome was based on the presence of borderline or clinical symptoms based on the cutoff point for the particular scale that was used in that cohort, because the different cohorts use different scales to assess the presence of ASD symptoms. And they were also ascertained at different time points ranging between 4 and 12 years of age. So a lot of heterogeneity in these different cohorts, as you can see reflected in the prevalence of the exposure. It ranges from 14 to 56%, and the prevalence of the ASD symptoms, which ranges from 0.9 to 12.9%. But after they sort of pulled all of the results from these individual cohorts, the relative risk was 1.19, stronger in the boys than in the girls. What I want to draw your attention to is really also the heterogeneity in terms of the strengths of these associations, which really range from 0.89 to 1.87. And 2 of the studies, the one I highlighted in gray here, are actually the same studies that we already discussed, the Spanish study and the Danish study. But if you remember, the relative risks here are different from the ones that we have seen before, which is due to the fact that the outcome was measured in a different way. Again, showing how sensitive the findings are going to be to how the outcome is going to be ascertained. Moving on to the ALPIS study, which was published last year. So this study used data from the national registries in Sweden, included close to 2.5 million pregnancies. Exposure was assessed based on either interviews with midwives and physicians during pregnancy, and after a couple of years also based on prescription records. Outcome was based on ICD diagnosis. And here I wanted to highlight, like, this is, I think, the first study where the investigators really tried to have a comprehensive adjustment for confounding by indication and other individual level factors. They also tried to get at that genetic component through the sibling analyses. In their crude analysis, they had a relative risk of 1.26, which is not that different from what we have seen in some of the earlier studies, but after adjusting for really a comprehensive set of potential confounding variables, it attenuates to very close to the null at 1.05, a little bit of further attenuation in the sibling analyses. What is interesting about this study is that they also looked at the associations for some of these other medications that are used for similar indications and actually observed that the association for acetaminophen was at the same level or even a little bit lower than for some of these other medications. Moving on to the last study, the Akubo study, which was published just recently in September. It is a cohort study using data from Japan. In terms of design, it is very, very similar to the Swedish study. The main difference is that their exposure is based on prescription fills, because in Japan, the OTC use of acetaminophen during pregnancy is very, very low. In terms of their findings, so they used a propensity score matched approach. They had 42,123 PS matched pairs, but their estimate is very close to that of the Swedish study, remember. So here the relative risk is 1.07, and again in the sibling analysis it attenuates. They do provide estimates for timing of exposure during pregnancy, where during the first and the second trimester there's really a null finding. In the third trimester there's a little bit of an increase. We don't have time to go into it right now, but hopefully during the panel discussion we can talk a little bit more about that. But to bring it all together, I sort of dismissed the G study because I feel that that study has such a high risk of bias due to selection. In terms of the studies that I sort of considered at medium risk of bias, what I wanted to emphasize here is really the heterogeneity in the findings. One study found an increased risk in the males, but not in the females. Another found increased risk in the males and a protective effect in the females, and the other one did not find a differential effect based on the sex of the offspring. And then 2 studies found consistent findings across ADHD study, and then 1 study found that the risk was particular in kids that also had hyperkinetic symptoms. And then the 2 studies that I considered as lowest risk of bias show a very small increase in the conventional analyses with no further increase in risk in the sibling analyses. So what are the take-home messages from my point of view? I think the evidence base for an association with autism spectrum disorder is extremely weak. There was no evidence of a correlated trend to begin with, as I tried to illustrate, so that sort of refutes that original hypothesis. The studies are very heterogeneous in terms of the design, in terms of the analyses. The findings are very inconsistent, and the associations are small to moderate, could easily be explained by residual confounding. And most of the studies are actually affected by multiple biases with hard to quantify net effects, because some of these biases will bias away from the null, like the residual confounding, and some will actually bias towards the null, like the misclassification of the exposure. But based on this evidence in the human studies, I don't think there's an evidence-based rationale to revise the current treatment guidelines, which suggest to only use it when medically indicated for the shortest duration possible for at the lowest dose possible. So to conclude, just a couple of considerations moving forwards, things that we sort of learned from this review, and I'll just be very brief. Sonia will pick up on a lot of these issues in a lot more detail later on, but most of the use is really for migraine, headache, and pain, and not for fever. I think the biggest challenge in anything we're going to do moving forward is really the potential for exposure misclassification, which is really hard to get a handle on. It's really hard to get the timing right, to get the duration right. And one question that we really haven't been able to answer is, and the question that I think is important from a clinical practice point of view is, like, what about the comparative safety for the different medications that are available to treat these indications that often require treatment during pregnancy? So thank you so much.